left pleural effusion has decreased breath sound on the left side on auscultation. What do you think? I have pleural effusion on the left side. This is my lung, right? This is my trachea coming. And this is my left. And there's fluid here. If I listen, there's a decreased breath sound. Is this something you should worry about? Or is this something that you said, okay, that's fine. This is what I expected. This is not a breathing problem. I'm being sharp, right? So I'm looking to consent. So if they put it together with 4 questions and they say, who do you see first? He said, well, the guy has fluid here, and I listen, and then breath sound is decreased. Well, that is what is going to happen if there's fluid here. Just because it's a pleural effusion, if you understand the pathophysiology of pleural effusion, you can understand that this is not the problem. You have a fluid there. If I listen, I'm not going to hear things. It means decreased breath sound. It does not mean I have shortness of breath, right? If I say shortness of breath, I'm having symptoms. Listening and there's no breath sound is no symptoms. It's just physical finding. And therefore, this is not a priority that you should pick. If they give it to you, you said, I don't worry about it. Number 7, a client with the left chest tube for pneumothorax has intermittent bubbling in the water cell chamber 1 hour post-tube placement. It's a bunch of words. Don't worry about it. Think about it carefully. Think about it carefully. It's a bunch of words. What is the problem? I said, patient has pneumothorax. So this is the same thing. This is the chest, right? And we put a chest tube here. 1 hour. When you check, there's intermittent bubbling in the water cell chamber. In the water cell chamber, there's intermittent bubbling here, like that. This is the water cell, this is the suction, and this is the collecting, this intermittent. Is this what you're going to see when you have a left chest tube placed for pneumothorax 1 hour? Are you going to see intermittent bubbling? Is that a bad thing to see? Should you call the doctor? Should you call for emergency? You said, this is a problem. I got to fix this. What do you think? Is your content? If you need more, just check that up. I have a bunch of videos on chest tube. So what do you think? This is expected because it's a pneumothorax in the chest tube. So in a 1 hour, you should expect intermittent bubbling as the air gets escaped. And then after a couple of days, you should not see any bubbling anymore. Continuous bubbling right away is a problem, but intermittent bubbling within a few minutes is okay. A client with Raynaud disease with blue fingers and toe after cold exposure. Like I said, these are content. Your board is all content. And you ask yourself, a Raynaud disease patient, what is their normal finding? So you can see that these questions are not difficult if you know. That's why I highlight the buzzwords, right? Raynaud disease, the first thing that should come to your mind is what you know about Raynaud disease and what will happen to them if they get exposed to cold or they get exposed to warm, extreme cold or extreme temperatures, right? They will have vasospasm, blood flow to their fingers will go down and their toes. In the process, what is going to happen? They're going to get cold. So this is an expected finding you should expect in a Raynaud patient. It's not something you should worry about it. His toe is blue. Yes, that's what I expect his toe to be. I'm not going to freak out about it. That's okay. So this one is fine. A client with coronary disease has severe calf pain when walking, which is relieved at rest. What do you think? Severe calf when walking that is relieved. What do you think is going to happen to that patient? It's a severe calf pain. It's a coronary disease. He has a severe calf pain. What do you think is going to happen to that patient? The definition of coronary disease is the same thing as PAD. So this patient, since he has coronary disease, he should have PAD. If you walk, you're going to have pain, claudication. If you stop, it's going to go away. That's normal. That's not something you should worry about. And therefore, we high-five each other and we said, let's go. It doesn't mean you don't care. It means on your test, you don't worry too much about it with the word severe, because all these prioritization questions are traps. They will trap you and then you pick it and then you get into trouble. So don't pick it. Number 10, a client with coronary disease has a nitroglycerin patch placed on a shaved skin area. What do you think? This is teaching, right? How do you teach a patient who has patch nitroglycerin? Do you tell them to shave the area? Do you intervene in this patient that don't do that, you get into trouble? Or this is the teaching you provide? You should not place it near bone extraction. You should not place it on a shaved skin. You absorb all the nitrate, you get into trouble. It's supposed to be a patch, slow absorption. We don't want cuts in your skin. And so this is something you should worry about. A client with glaucoma is prescribed dicyclomine for irritable bowel syndrome. This is content, like I said, prioritization. I see it as a content. If you know your information, no matter what, they can trick you, they can do whatever. You just have to you can figure, you can eliminate. I do this, I'm not putting them into four. I want you to look at them isolated. If you think about it like that and you are not comparing answers, I know people teach you to compare answers. No, don't. Just look at the individual information and said, oh, this is normal or not normal. If not, you just eliminate it. So if they give you 4 and you've been able to eliminate 3 without not comparing, you see that the answer will be like that. You pop up like a candy. There's no need to compare answers, right? You have to try to look at a case individually, right? So you have to go back to your content and say, I've highlighted the keywords, the buzzword. What should you know about glaucoma? That I would say dicyclomine and irritable bowel syndrome. Dicyclomine is anticholinergic. It's used for irritable bowel syndrome. But anticholinergic is not good for glaucoma. That's why it's a problem. Antihistamine, anticholinergic, and decongestants are 3 things you should avoid. Anticholinergic, antihistamine, and decongestant. If you have glaucoma, you should avoid. Therefore, this patient or the nurse should say, no, you can't have it. It's not good. So you can use the dicyclomine for irritable bowel syndrome, fine, but the dicyclomine is not good for the glaucoma. Watch for this kind of prioritization. The medication is good for another, but it's not good for another condition you are having. Those are trapped, right? It's okay to have dicyclomine for irritable bowel syndrome, but I have glaucoma is contraindicated in me. It will cause more problem. Buzzwords. The clients with bipolar, what is the problem? It's on lithium. It's prescribed what? Motrin for knee pain. Same strategy. Motrin is good for knee pain, right? But is it good for patient who has bipolar and is on lithium? That's the way you read a question. Think about it. It's a test-taking strategy. This is the way I do test-taking strategy. Think about it. You don't have to memorize anything. Ask yourself, Motrin is good for the knee, but does Motrin good for bipolar patient on lithium? If it's not, then you pick, you say, no, that's bad, right? That's bad. So what do you think? Motrin is good for the knee, but it's not good for the lithium. If you take lithium, you should avoid NSAIDs, you should avoid hydrochlorothiazide, you should avoid ACE inhibitors. So this patient, this information is concerning. A client on haloperidol for agitation is prescribed diphenhydramine. Is this a problem? Like I said, it's all content. You can create your own NCLEX question. There's no magic to it, right? If you go and look at QBank, there's no magic. They just make things up, like the same thing I've made, right? Haloperidol for agitation, and I'm prescribed diphenhydramine. Look at the combination, test-taking strategy. I have a bunch of videos on this, how to answer questions, test-taking strategy. There's a reason why there's three things here. Haloperidol, agitation, and diphenhydramine. If you're agitated, we'll give you haloperidol. This is what? First generation antipsychotic. What does it cause? EPS, NMS. How do you prevent them? Especially EPS, we give you anticholinergic. Diphenhydramine is an anticholinergic. That's why it's on diphenhydramine. So we're giving them diphenhydramine to prevent extrapyramidal side effects, because the first generation antipsychotic can cause extrapyramidal side effects. So in order to mitigate it, you can give them anticholinergic. Diphenhydramine is an anticholinergic. Therefore, this is not something you should worry about. And it's based on content. I like number 14 because it's great one. It's an infectious disease. I set it to show you they can do this with anything. That's why prioritization has no limit. It's content-based, right? Prioritization is content-based. What do you think about 14? Type your answer if you know it in the chat. A client with unencrusted lesion over the mouth and face is placed in droplet precaution. What do you think? What do you think? This buzzword is unencrusted lesion. What is that? What do you think? What do you think? An unencrusted lesion. A client with an unencrusted lesion over the mouth and face and is placed in droplet precaution. You got to bring your content. You got to bring your content. You got to bring your content. What is unencrusted lesion in the face and the mouth? Who knows it? Who knows what unencrusted lesion in the face and the mouth? Don't fall for words in the question. I mean, try to make it sound your own. Unencrusted lesion over the face and the mouth is impetigo. Impetigo, what kind of precaution you should institute? Contact precaution. Patients in droplet precaution. Everybody is infected. This is concerning, right? I know they will not ask you that. They will ask you which one you should intervene, but I'm framing it in this way so that you can think. You can get used to see abnormal findings. You can intervene. You can educate. That's why I said a question like that. This is worrisome because unencrusted lesion is impetigo and you require contact precaution, not droplet. Therefore, this is no problem. It's a problem. And look at the 15. A client with crusted vesicles along the frank area. That's the buzzword. If you can figure out what is crusted vesicles along the frank area, I'm placing a standard precaution. What is a crusted vesicles along the frank area? Well, what do you think? Well, what do you think? Who knows what is the crusted vesicles along the frank area? What is that? What is that? This is vesicles that tell you this may be shingles, right? This is shingles. It's along the frank area, so it's along the dermatome area, the shingles. A crusted lesion, even if it's a varicella and it's crusted, it's no more contagious. So you need a standard precaution. So we're doing the right thing. Because it's crusted, it's no more infectious. A chicken pox is usually don't go along the frank area. This is sound like a shingles, but even if it's crusted, they are not contagious anymore, right? A client take quetiapine reporting daytime sedation. So this is just straightforward, right? You have to understand the pharmacology. Who know what quetiapine is? Quetiapine is antipsychotic. It's a second generation antipsychotic. And they cause sedation. It's okay. Don't worry about it. Right. So 16 questions so far. You learned something? Yeah, it's content, it's broad content area. And thank you for coming to our adapting class. This is Saturday review we do every 3 to 4 p.m. Eastern time on Zoom. What do you think? Number 17. I'm taking methylphenidate. My heart rate is 109. Methylphenidate. It's a stimulant. If you take a stimulant, well, your heart rate goes up. If you take a stimulant, your heart rate is going to go up. So this one, we're not going to be worried about it. Number 18 is a trap. And if you know your assignment, this is key. One of the key concepts about assignment. A client is ready for discharge post-appendectomy. So he's going to go home. He's assigned a mental health floatiness. So he's assigned to a mental health floatiness. It's okay? You should say assigned to a mental health floatiness. So this client is post-appendectomy. That means we are in the med-surg unit. And we have a floater from the, who is a mental health nurse. Is that okay? Patient is ready to go home. Patient is ready to go home. If you know your assignment, this is one of the key content related to assignment. It sounds like easy, it sounds clean, but there's a trap in it. There's a trap in it. When it comes to floaters, you should not assign to them admission, discharge, and a new patient post-op. This guy is going on, require a lot of teaching. Mental health nurse has no clue about appendectomy. She should not discharge this patient. She should not be assigned to this patient. So this is concerning. It's easy to mix it, but she should not be assigned to that patient. A client with End-stage renal disease, he was receiving Epoetin infusion as a morning hemoglobin of 13 grams. This is also content you should know about this medication, Epoetin Alfa. It's given to renal disease patients to improve their hemoglobin because they cannot make it. But there's something about it. When you give it to them, it should not go past 11 grams. This is 13 grams. It's a problem. It will cause polycythemia vera, and it will cause headache. And it's emergency. So you should not increase it past more than 11 grams. This is 13 grams. It's still bad. You should worry about it. It's always a trap, this one. We're supposed to increase the hemoglobin, but you shouldn't go past 11 grams because it's going to make it worse. And the last one. A client post-exploratory laparotomy has no bowel sounds 18 hours after surgery. Is this something we should worry about? Is this something we should worry about? Well, we just had surgery. It's 18 hours. It's okay. It's okay. There's nothing to worry about it. So these are very short questions. I mean, 20 of them. If you need more, you can, this is part of my on-demand. Subscribe to the on-demand and get to it. Or every Saturday, join us at 4 p.m., 3 to 4 p.m. on Zoom. You can check the Zoom link and then you can join us.